I definitely think that the more we can hone in on A, the right population of patients, and B, the right drug to hit relevant genomic targets, the more successful we're going to be in treating bladder cancer. When we think about agents like dovitinib, for instance, the issue in the context of those trials might have been the affinity of the drug for a multitude of different receptors. Although dovitinib certainly has affinity for fibroblast growth factor receptor, the FGFR family of proteins, it also has affinity for multiple other kinases. And I think that may potentially lead to some diminution of its activity and some increase in its toxicity. So I think that's probably why agents like dovitinib probably faltered. I will say that beyond dovitinib, now we're of course very fortunate to have agents like infigratinib or dovitinib that really hone in on FGFR3. So beyond our ability to select patients with FGFR alterations, we're now really able to treat those patients with a much more potent and specific inhibitor, increase efficacy, limit toxicity.
So, Dr. Shroff, there are other TKIs that has been studied. Okay, we talked about very selective FGFR inhibitors, but there are also non-selective TKIs that has been studied. I think you've had some experience as well using a drug like pazopanib or pazopanib, and I personally have experience using regorafenib, and I'll talk a little bit about that as well. But the regorafenib has been studied in a couple of settings in cholangiocarcinoma. And the biggest difference between the study that we did versus the one that's doing FGFR is that we did not enrich anybody for FGFR fusion. We allowed all comers. And we had a study, a single-arm phase 2, 40-patient study. And the results were modest. Response rate less than 5%. And the overall survival was anywhere from 8 to 9 months. There were some patients who did very well. However, a single-arm study is tough to tell what the benefit the patient is going to derive from. However, at GI ASCO this year, there was a trial done in Europe called the REGENT study, which was a small randomized phase 2 study where they randomized to placebo versus regorafenib. In that study, the primary endpoint was PFS. And they met that endpoint. It basically doubled, going from 1.5 to 3 months of PFS benefit. There was no difference in overall survival, but it was not powered to show OS benefit. But without enriching patient population, it's tough to say that whether this kind of what we call non-selective TKI will work as well in patients with FGFR fusion compared to those very selective TKIs. So, in your experience, I know you've done study with other TKIs as well. So any comments about other TKIs that you have?
Yeah, I agree. I mean, I think, unfortunately, we had a study with pazopanib and trametinib, for instance, and, this was before the true understanding of how important these actionable alterations are and how much of a driver these FGFR fusions and such are. And so we saw a low amount of activity, but it was not a selected population, and I think that's where we were remiss. But I do have to ask, with these multikinase inhibitors, do you worry about additional side effects?
Yes, by blocking other pathways, you're going to get more side effects. So I think we talked about side effect that's caused by the pan-FGFR inhibitors. But by blocking VEGF, PDGFR, other receptors, you're going to get hypertension, hand-foot skin reaction, motor fatigue. And that's been sort of the dose-limiting stuff, as you know, with other, what I call A30 TKI. So yes, I think if you block other pathways, if it's not a clean TKI, you'll definitely, I think, would get more toxicity that you have to deal with, other than your typical FGFR toxicity you see with.